Welcome to the Young Surgeon Symposium on Business Management. So I'm Jay Turner. I'm going to be moderating. I'm a neurosurgeon from Phoenix. We have an esteemed panel of speakers that are going to be joining us to teach us a little bit about business management. This is a critical topic for our success as spine surgeons, and I think the SOLAS leadership has correctly identified this as an area that's really undereducated in our training programs, and so I think this is we have a broad range of topics being covered, but I think it's all very apropos for budding surgeons starting their careers. So we're going to start with Dr. Raj Sethi, who's going to be joining us via the web. Dr. Sethi is from Virginia Mason. He's the director of the Neuroscience Institute there, and he's really one of the eminent leaders on quality and safety, and a lot of the financial models that have started to emerge, and really has this kind of finger on the pulse of where things are heading. So excited to have Dr. Sethi here. Do we have audio? The mic's all yours, Raj.
Okay, Jay, can you hear me?
Yep, we can hear you.
Okay, all right. So I'm going to talk a little bit about the current state, but really focusing on the future state. So, part of what we're doing up here in Seattle is we're doing purchaser directed healthcare, which is a lot of these large companies now are buying healthcare directly from hospitals, and they're taking the middleman out of it. The reason is they insure large numbers of their own workers, as you know, and really what we got to start thinking about is population health, which is the health outcome of a group of individuals and the distribution of outcomes within such a group. And as we know, back pain and spinal disorders are a big spend, and so delivering value is this quotient, which is the outcomes over the costs. And this is obviously, for those of you that know Michael Porter's work, and he was one of the guys that kind of brought this to light. This is something that's going to be increasingly talked about as time goes on, particularly because of our spiraling costs of healthcare. So how do we increase value? Well, there's the idea of quality, there's the idea of outcomes, and then there's the idea of how to pay for it. We right now are still, the vast majority of us are in fee-for-service healthcare scenarios where we get paid for the number of procedures that we do. Some of us get paid by collection, some of us get paid by RVUs, some of us have a mix. But very few American surgeons outside of the traditional HMOs are actually salaried at the current time. And so then we have to start talking about this quantity of care idea. What are the incentives to treat? What are the resources? And what is the value in the setting of all this? Now there's a new topic that's come up, and obviously we are doing a lot of work around value-based reimbursement for total joints, for spine care, for cardiac care, and for bariatric surgery. Now, value-based reimbursement can be split into two areas. There's the idea of bundled payments, and then there's the idea of capitation. Okay, so what is capitation? Capitation is cost per patient per unit time. Risk is spread. Improvement is at a population level. You're choosing the best health systems. You're basically putting health systems against each other as to figure out who can spread this risk the best and who provides the best outcome. Now, the outcome might be a financial one in the case of a large payer like JetBlue or Walmart or one of these large companies that wants to control its own costs. It can also be in the eyes of the patient when you're at a working age. Are you getting back to work? So that, remember, beauty's always in the eye of the beholder. The whole idea about bundled payment is that it's an entire cycle of care. You get one payment no matter what happens. It is contingent on delivering outcomes, and you're carefully adjusting for risks because you're not getting paid for readmissions. You're not getting paid for so-called never events. So that's the whole idea of a bundle, and it's a fair profit for efficient care. Now, what is cost effectiveness? And I'm sure there have been some papers there at this meeting that have talked about what cost effectiveness is. We have determined that our cost per quality adjusted life year has to fit in this certain threshold between $50,000 and $100,000, and that's really what the willingness to pay threshold is. This is a great article from the Yellow Journal, which I really would recommend a lot of our young surgeons read, because this is really where we got to start getting involved. I actually gave neurosurgery grand rounds at Calgary this morning. That's why I can't be with you guys. And I had their entire neurosurgery, orthopedic, and anesthesia group in the room, probably about 80 or 90 people, and I asked them to raise their hands if they felt comfortable with health economics, and nobody raised their hands, right? So because this is a subject that's nascent in our medical school curriculum, it's nascent in residency training, we've got to start to do this on our own, and there's some good basic articles that we read. Now, on the top of this, we've got this whole idea of the employer-led healthcare revolution. This article is one of the most read Harvard Business Review articles in the last couple of years. And a colleague of mine up here in Seattle, he's really helped. He's an endocrinologist, but he's really interested in spine delivery, on how health plans are going to have to start reimbursing providers on the basis of quality, and they're unwilling to pay for what they deem as unnecessary things. Now, if you go to Pike Place Market, you know what you're buying, you know the cost of it, and you know what it looks like, what it smells like, and what the quality is. However, when you're purchasing healthcare, at this point, both quality and price are still on the table. Then there's the idea of predictability, right, which is that the lay press is writing about us in spine care, saying that we have this avalanche of unnecessary medical care and we're harming our patients physically and financially. This was Gawande's New Yorker article where he specifically talked about spine care. So we've got to do a much better job for the area of accountability, which is that the idea that, for us deformity surgeons, we're doing these large surgeries with these massive complication rates that we're just going to keep paying paid because the hospital contribution margin is associated with higher occurrences of surgical complications. Well, that's kind of a way of the past, and that's not going to happen anymore. At the same time, we know that from an epidemiological standpoint, we're going to be inundated by patients with degenerative spinal problems and spinal deformities. So we've got to come up with a more sustainable algorithm to take care of these patients. There's lots of literature on the fact that non-operative management doesn't help a lot of these patients, and we know that centers of excellence work is growing large numbers per quarter. So we've used a little bit of an improvement methodology in our own system, and we've written a lot about this, of how we tried to adopt standard work and how we've made the standard work ubiquitous amongst the surgeons, whether they're neurosurgeons, whether they're orthopedic surgeons. Our standards are all the same as to how we're going to surgery, and how we are involving things like multidisciplinary conferences, how we're using 2 attending surgeons, even if we have fellows, how we're reducing our complications by bringing up standard work. And we've also been looking at how you use these conferences and other people in the decision-making tree, particularly physiatrists and anesthesiologists, to come up with better recommendations for surgery, and then marketing this. And a lot of this is all around population health, cost, and value. And what we're seeing is if we take large populations and deliver a more of a standardized approach to care, we're able to reduce all of these complications that we're seeing, particularly in scoliosis surgery, but even in routine spinal surgery, by choosing patients better, optimizing weight, optimizing smoking, optimizing mental health, and things like that. And where we're seeing the important improvement is in the first 30 days, which is where we're getting a lot of our bang for our buck in the more difficult cases, and saving a lot of money for these payers. Now, you may think that this is a uniquely American problem, but it's not. I probably learned the most recently on a trip over to the UK, and I borrowed this slide from Ashley Cole, who's the lead spinal surgeon to the UK government on this spinal working group, and they've been cutting their budgets year by year for spine surgery, and it's the same issue, right? It's not cost effective. We have little standard work. We have perverse incentives. We've got private payers, governments that are fed up. I think point number 4 is that we have to understand healthcare economics and delivery so that we can build better systems and we can work together in an unsiloed approach to have better systems. So again, I think we crave standard work, and this is what's going to help us deal with the access issues. And we have to be able to develop these standards so that we're all operating on the same patients, using something like lean methodology to help us figure out what our standard work is. Now, this hasn't changed very much. Many of you will recognize that this is the Dartmouth Atlas, and this was the utilization of spine surgery back in the early 90s. Well, guess what? It's been repeated, and there's still this dramatic variability all around the country. So we got a big nut to crack here, and that's really important. Now, part of this is going to be how you build a system around yourself as you're a young surgeon to make sure that you're mitigating risk, that you're involving your anesthesiologists, pain doctors, your physiatrists in the decision-making process. Part of that, we think, is getting everybody in the same room and discussing all of these patients. We've had a large number of these now from all regions of the United States over the past 7 years in terms of getting team assessment of these patients. Now, quick example, here's a 71-year-old female who's badly disabled with a high ODI. She's got a high ASA score. She's osteoporotic. Her Forteo was denied by our insurance company. This patient does not get surgery in our setup. We don't try to go do some Hail Mary on this patient. We just don't operate on her, right? And that's because we can't optimize her bone health, and we think that this is going to be a cost-ineffective surgery. Again, the standard scenario of many of you seen patients like this: 14 previous spine operations, multiple non-unions, the patient's still smoking. She tells us that she stopped smoking. However, her urine cotinine is positive on 3 occasions. When we map this patient, she needs this massive correction with 2 pedicle subtraction osteotomies and a big correction. We are not doing surgery on this patient until we ensure that she's optimized. And optimization in this case is smoking. Here's another patient. Horrible films, badly sagittally imbalanced, a severe fractional curve radiculopathy, on a fentanyl patch, very depressed, anxious, catastrophizing, suicide attempts, nobody at home. In our neuropsychology eval, she gets a red, which means she's severely challenged from a neuropsychological standpoint. This patient does not get surgery. This patient has to undergo significant optimization before we can go forward with surgery. And then maybe a year afterwards, we do something like this. So again, aggregating independent judgments of doctors outperforms the best doctor in a group, and that's really an important part of delivering quality and value in spinal disorders and complex spinal disorders. Now, for the last 2 minutes, I'll just tell you what I think the high-value care of the future is going to look like. And I think what this is going to be is all around predictive analytics and being able to predict what you're doing and provide a warranty or a guarantee, right? And this is going to involve system-specific risk and bundles on something like this. Here's a 60-year-old female who has a high BMI, who's anemic, who does not smoke, who's not hypertensive but diabetic. In our system, this patient's got a 92% probability of complications. This is a case we're not going to bundle. This is a case we're not going to warranty. And if this case comes in through one of these centers of excellence payer groups, you may have to say no to this patient, right? If this patient is coming in a different channel with a different payment algorithm, you may be able to go forward and stomach the 92% risk of complications and do her 5 operations in 6 years to try to get her better. This is the opposite example of somebody who's going to sail through, right, a major operation with a significantly lower risk of complications. This might be one you'd want to bundle or one that you want to give a guarantee for in some of these new payment algorithms. So this is all around within your own systems. I have talked a lot about you have to be able to stratify risk within your own system. And we have generalized risk calculators. The problem is that's like a stew with 18 different types of meat in it, and you have no idea what you're really eating. These system specific risk calculators, I think, are very important in the future. So in conclusion, we got to standardize, increase patient safety. We have to use pathways, protocols, and dashboards. I think high-level medical center administrative support is necessary to make these changes. And for the young group in the room, all around payment reform and new payment models, it's all going to be around choosing patients better and saying no much more than we currently do. We've got to figure out who we can fix and fix them really well. At the same time, centers that do it better and standardize this care are already going to get increasingly rewarded. And my hope is that surgeons will lead the efforts. Thank you very much.
Well, thanks, Raj. Really appreciate you joining us amidst your travels. We'll move on to our next speaker. Keith Humes is joining us, CEO of Rosemont Media, and is going to talk to us about marketing strategies for the young spine surgeon.
Thank you. Hey, good afternoon, everyone. How many of y'all have a website for your practice? Show of hands there. Oh, great. Cool. So everybody knows the importance of your website, and especially in attracting new patients to your practice. It's a big part of your reputation as well. Patients may hear about you word of mouth, but then they go to the web and research you further. Again, I've been marketing with dentists and surgeons for over 20 years now, so I've seen a big change. Seen also a big shift. I primarily was involved with web marketing for elective healthcare, and now I'm seeing more and more businesses that are relying on reimbursed healthcare now wanting a better web presence and a prettier looking website, because it is an important part of the practice. Again, my disclosures are we're partnered with Yext, which is a location management tool, and we're also partnered with Google. We're a premier Google partner. So I'm going to talk about website development. Again, my goal here today is to cram an hour of information into 15 minutes. I'll see how I do here. But I'm going to touch on website development, a very important part of the whole process. It's essentially your foundation of your web strategy. And responsive website design is kind of the standard now. And so what responsive website design is essentially one design that lives under one domain name and fits multi-screens. So it works on all screens because it's very important that you're optimized for many different screen types. And so here's an example of the same website that sizes down to a tablet size, and now you can see it sized down to a phone size. Again, this is one website that works, again, with different screens. So early on when I started in web development for mobile, it was a really exciting time. Obviously, the advent of the iPhone really kicked off mobile marketing. Now we're starting to see 70% of users are actually on mobile devices now. The traffic's going through the roof on mobile. So early on when we started developing for mobile, we developed a website, a main website, and then it sized down to an MDOT. Well, how you got to the mobile version was through a mobile detect. And so it detected the device you were on and then reacted. So we've gone full circle, and now it's reacting to screen sizes as opposed to devices, because it got to a point where there's so many devices that were coming out that it was impossible to program the websites to react to these different devices. And so now that's why responsive is the best way to go, because you just have to develop on one site and keep one site updated. Before it was, before you have a mobile version that you had to keep updated independently from your desktop. So it became a huge hassle to keep both of those, all those different versions updated. So that's why this is the really great way to go. So when we talk about, I'm a big advocate of custom website development, a lot of templates out in the marketplace, but I think for your business, the way to go is really custom development, because in marketing and branding, you want to have a unique brand that makes you stand out in the marketplace. If you have the same website that your competitor has down the street, you're not going to stand out. You're not going to be different from the crowd. So branding is a really important part of the whole process of web development. And there's a lot more flexibility with a custom website as well. And budget, you kind of think about budget, okay? It's easy to get into a template website, again, because it's off the shelf, it fits everyone, you change out a couple pictures, and bam, you got yourself a website. But there's always ongoing fees that are involved with a template website. A lot of times when you start adding up those template fees, ongoing fees, because usually monthly fees, anywhere from $200 to $500 a month, when you start adding up those fees over time, I think what you're going to find is if you pay a little bit more upfront, you get yourself a custom website, it's yours, you also own it, it becomes an asset of your practice rather than a payment. And I've been part of many business sales of practices in both dentistry and surgical practices as well. And the website becomes sometimes more of a valuable asset than any of your equipment that you may have in your office, because it's generating patients. And again, the content, everything about it is part of your practice. So again, be wary when you're getting involved with the website. If you bought a custom website, it was being portrayed as a custom website, and the turnaround time is very quick, be wary of that, because a custom website takes time. It's actually, built, all the pages are built by hand. They're all coded out based on the custom design that you have. So if you're getting a custom website that's turned around in a month, you may want to be wary whether that's an actual template or not. So the content is a big part of search engine optimization. Again, I could talk for hours just on search engine optimization. But when you look at a website, the most important part is creating potent content, good content, so that you become the expert in your marketplace. And that's really the driver of search engine optimization. So here's an example here. This is a dentistry search here, porcelain veneers San Diego. This is an actual page that I found on page 100 or something under this search. This is all there is to that page. So when you think about search engine optimization, if you want to compete in the marketplace, you're going to have to create a web page that has much more robust content. So here's a page, again, on porcelain veneers that is much more robust, tells a story, gives you all the information, has a video with a patient telling about their experience. You tell me, again, looking at the other page, looking at this page, which page would you index under that competitive search more? Again, you're going to index the page that has more robust content. Google loves content. You want to feed the bot. That's basically what you're trying to do with search engine optimization. There's really fancy ways of looking at search engine optimization, but at the end of the day, the goal with search engine optimization is to turn your website into a resource for your patients who are doing research on the procedures that you're providing and to position yourself as an expert for that specific procedure. Site speed is another huge thing. So again, what Google talks about since day one, since I started working with Google in 1999, is they're all about the user experience. And they want to create a good user experience for those that are going to Google. That's how Google makes money, by selling ads. And so if they're not giving a good user experience, then people will stop coming to Google. So one of the huge things is website speed, especially on mobile. So you want to make sure that your website is loading fast. I'll give you a great place to go to test your website speed. It's called gtmetrics.com. This is where this test was taken here. And you can plug your website in there, and it'll tell you how fast your website loads. Many factors on website speed. Server optimization is huge, as well as the development of the site, how the site's put together, how the images are compressed. That's what you're paying for with a custom website, is to make sure that it's going to pass all these tests, and you can always tweak it and evolve it and change it. But website speed is a huge ranking factor. Just this year, they're rolling it out as we speak. They're rolling out a new index, which is called Google Mobile First. And what they're doing is they're ranking, whether you're on a desktop or you're on a mobile device doing searches, they're ranking websites based on your mobile website now. So wherever you go on Google, your placement on your desktop, you do a desktop search, it's going to be based on your mobile and what you're doing on mobile. So it's turning into a mobile-first world with marketing for websites. So mobile is the first thing that you should be looking at when you're developing your site as well. Think about what you want on your mobile site first, because you can always expand and go bigger on your desktop, which is really nice. But mobile is really a big factor and really where you want to go. So there's a couple quick takeaways on SEO. You want to create potent content. You also want to look at duplicate content. You don't want to take content from your buddy who's in another market, because that's just not the way you're going to make your website a resource. Dupe content is the #1 no-no on Google. You need to create unique content. That's why there's a value to good content, because duplicate content is a big no-no. So you want to make sure you also have ongoing content marketing plan. You want to expand your pages over time. You don't have to create the biggest, greatest page your first round. You want to have a system and plan to develop that page over time, because that adds more value, and then it keeps you ongoing and competitive in the rankings as well. Links are a big part. Again, I could talk more on links, but I want to have some strategy of link monitoring. When I go back to dupe content, talk about duplicate content, it's interesting, because not only you have an issue of you taking somebody else's content and put it on your website, or working with a developer that may have stolen somebody else's content, you also have an issue of people stealing your content, in which we deal with that a lot. So people will say your content's really nice, you spend a lot of money on your content, and somebody steals your content, and they're getting better ranking than you, because Google's giving credit to them as authoring that content. So it goes both ways. So that's why you have to make sure you're doing annual dupe content checks. And if somebody does steal your content, then you have to go out and contact them and say, hey, take my content down, that's mine, it's been copyrighted to me. So that's a big part of what we do. We do annual content checks all the time. Make sure the content that we have for our customers is unique, and that nobody else has stolen that content as well. And again, I touched on speed. Speed is a really important part of website these days. It's going to be one of the #1 factors for ranking as time moves on here. Again, you need to ask yourself that question over again. Is my website a resource for the procedures that I'm providing? Direct ad buys, Google AdWords, I'm just going to touch on this briefly. You want to try to go with a Google Premier Partner. Google Premier Partners, it only represents about 3% of the agencies in North America, but these are the agencies that Google has hand-selected because of a lot of variables, a lot of factors, such as how many campaigns have they managed, the longevity of accounts, the ad spend that they're handling. You know, their goal and our goal as an agency is to make AdWords work for you. The other issues can be budget. You may go with a company that's going to charge you $1,000 a month, but then they're only spending $200 with Google and they're pocketing the other $800. So the other problem with that is that you want to know exactly what are you spending directly on Google. So when we do ad buys, we're very transparent. Our clients know exactly what they're spending with Google, and that's a very important part. Because Google will get calls. They say, hey, I'm spending $1,000 a month with this ad agency. Google AdWords doesn't work. Well, then they look at that agency and find out actually they're only spending $200, and so Google obviously gets a bad rap because they're not getting the full budget that they thought they're spending. So the practice doesn't think that AdWords works, which obviously is something that Google doesn't want. So make sure that your account is also portable. So if you do have an AdWords account set up by an agency, you want to make sure that your AdWords account is set up in your name. All of your Google suite of products, including your analytics, your Google My Business, which I'm going to touch on here today as well. All those things should be housed under your name, under your practice name, so that those things are portable. Because the data is so important. If you're spending good money on AdWords to promote your procedures, you want to have that longevity of history of ad spend. And without that data, you don't know when you're starting from scratch again. So that data is very important when you're talking about Google AdWords. So again, I touched on make sure it's set up under your practice name, go with a Google Premier Partner. Of course, you want to also track the emails. You want to have some sort of system to track emails and phone calls because you'll never know, because we usually see the majority of leads that come in are actually via the phone rather than email. So if you're not analyzing your traffic, analyzing the quality of the visits, then you'll never know whether AdWords is working for you. Obviously, very important, online reviews, local optimization. Has anybody heard of the term citations, citation management, the term NAP, name, address, phone number? So that's all what citations are. They're your NAP, name, address, phone number. Really big part on the web to make sure that's standardized. The problem now in the web is there's just tons and tons of directories out there. I'm sure you guys have seen it. You do searches under your name. There's health grades, there's rate MDs, there's your organization that you're part of, there's your practice, there's your web page, there's all kinds of things that are now come up under your name. The foundation for your citations and your NAP is Google My Business. It's also the foundation for your SEO strategy with your website. If your Google My Business page or Google Local, it's gone through many changes in names, is not tied to your website will not perform well on the search engines at all. It's also places where your reviews are housed under your name, under your practice name. It's free still. You know, so many of you seen this. You do a search for a practice name. This is a dental practice example, a local one here in La Jolla. And again, this is where reviews are found. So this is what people are looking for your name. They're going to find this. So you need to make sure this is optimized and tied to your website properly. The other thing on mobile is people are going to call from their mobile device. They're on a mobile phone. They're doing searches. It's really easy to hit the call button there. And Google's tracking this stuff. And so what we have found is there's been a big uptick in activity on Google My Business through the phone, and not only for name searches, as you can see here, and we're seeing this in majority, is that not only are name searches being searched, but discovery as well. So you'll see here that direct is much smaller than discovery searches. So discovery searches are spinal surgeon, spinal doctor, orthopedic surgeon, orthopedic doctor, those type of searches. The map listing also comes up under Google My Business as well. So it's very important that you understand that you look at the insights and see what role Google My Business is playing for your practice. Because you're going to find here that there's a lot of calls that are coming through Google My Business that aren't trackable through your traditional analytics if you're not taking a look here. But also people looking for directions, requesting your website. A lot of activity going on here through Google My Business. And again, as I said, there's just hundreds and hundreds of places now where your name is found, and people are vying for your name because the other thing is that a lot of the searches on the web are doctor related. And so businesses want to grab That's why these businesses exist. That's why Healthgrades exists. That's why ZocDoc exists, because they're monetizing themselves under doctor name searches. So you better make sure that you're taking advantage of these different sites and that you are claiming these different sites that are out there. The best way to do that these days is through a location or citation management tool. One of the popular ones, and the ones that we're partnered with, is called Yext. And what that does for you, it allows you to manage all of your locations, your business name, and have it be uniform and organized in one place, rather than trying to manage 100 different listings across the web. So this is a very essential tool, and this is not going to get any easier. Every day there's new websites out there. And you know, there's ones that you've heard of, Apple of course, you know, but there's ones that you haven't heard of as well. But again, if these are off in any way, then it can be off in other places, and it really doesn't help your search engine optimization. Again, reviews are huge. Reviews are the gold now, the new gold standard in healthcare, and it's really an important part of the practice. Early on in my career, I was telling people they needed to check their email. And, you know, back in the early 2000s, we would monitor people, and they would go 5 days sometimes without checking email. So I feel that the practices are now really good at answering the phone, answering emails. Now the new thing is that integrating reviews into the daily routine of the practice is very important. So when you think about getting reviews for your practice, you need to ask for reviews. You need to try to gain reviews, because if you get a bad review, then what are you going to do? There's always that chance. Bad reviews are always going to happen. There's also a report out, the Stanford report, the positive effect of a negative review. So if you have 80 great reviews and then one bad review, well, people are actually going to think that your reviews are legitimate because they're seeing one bad review. Not every single person can be happy. But if you have a strategy to gain positive reviews proactively, then you're going to be in a better shape if you do get that one negative review. So again, you want to prepare, have a plan with your practice, within your practice, execute and reward and sustain. So what I mean by reward, one of the things that we've done, I've done with my staff, and I tell the practices I work with as well, is to reward your staff for getting good reviews for the practice. So one of the things I did is throw $10 bills up on the board. Every time one of my sales reps got a good review from my customers, they would take that $10 off the board and put it in their pocket and go get lunch that day. So not really, you don't want to reward the patients or incentivize the patients by giving them money, but rather give your staff a little perk and make it part and talk about it, you know, and ask how many reviews the practice is able to get. And it's really important to talk about reviews when the patients are happy. You know, that's a great time to do it. Of course, you can send out email. We've seen very little return on trying to get a review through an email. People just kind of ignore it. However, mobile has been huge, mobile review generation. So again, here's how it goes. Jay, you had a great experience at our practice? Great. Reviews are a very important part of our practice. Would you mind writing us a quick review? I'm going to send you a quick text message. Bam, goes right to your phone. The next thing, you click on that. It says, you know, did you receive exceptional care? You click on that link, it takes you right. So I've only basically 3 clicks, and I'm right into the review section. I'm in the office. I'm on a mobile device. I can click 5 stars right then and there. It's in the trenches. That's how you're going to get great reviews. Reviews drive the business these days. People look at reviews to make decisions on what doctor they're going to go to. And mobile and talking to patients has been the way. There's no real big way to automate reviews and gaining reviews. It's really through talking to your patients and trying to get it on site in the practice when they're happy. So it's a great way to go. And of course, if you're gaining reviews, you want to make sure you monitor reviews. And then you want to make sure that you show your reviews, your great reviews on your website, and put it throughout your site. Have some way to display those reviews. So again, Google My Business is the foundation of local. Consider a location management tool. It really does save time. Have a plan to generate reviews, display reviews, and broadcast reviews on your website. Social media marketing, really just going to touch on there. Be really quick here, but you want to be consistent in your brand, so you don't want to have a different name on your Facebook page that you have on your website. Let's keep all your branding consistent. Again, try not to automate your social media marketing. You're really not getting any engagement. You can clearly tell on your page. If you don't see interaction, you don't see likes, you don't see comments, well, your social media strategy is most likely not working. Just generate, or just having reviews streaming onto your page is not a strategy. And then also having an automated feed about healthcare stuff that's not related to your business is also not a good strategy as well. So you want to come up with a good editorial calendar, have a plan, execute that plan with a good strategy, and try to create engaging posts that are related to your business and monitor for engagement. Of course, unless you're SI, then it's very difficult to create viral content. It's impossible. So one of the areas with Facebook that works really well is paid promotions. That's really what's going to get you in front of people. Facebook is a huge billboard. You got to think about Facebook as a huge billboard with thousands of cars driving down the freeway. But you can create your own freeway by demographically targeting the patients that are typically in your demographic. So you can fine-tune the marketing to get to those demographics of people that you're looking for. Again, keep your branding consistent, skip automation, have an editorial calendar. Again, promoted posts are key. And you want to really monitor for engagement as well on your social page. It's not working. Email marketing is one of the still most cost-effective way. Just like you go responsive with your website, you don't want to go responsive with your email marketing. You want to make sure that your emails work on all types of different devices. If it's not optimized for mobile, most likely going to hit the delete button. 60 to 70% of people also check their email via their phone. So if it's not optimized for the phone, it's really easy just to hit the delete button. All right. Again, email marketing, it's a great way to go. You want to make sure you have great segmented lists, so that you can send out targeted emails based on your segmented list. And again, have a website subscribe form as well. Tracking, reporting. Google Analytics is the foundation for your tracking. You want to make sure, again, that your Google Analytics is set up in your name, under your account, just as any of your other Google products like Adwords, Google My Business. It's all together. It's portable. Whatever company you work with, you want to make sure that you can extract that. If you want to leave that company, you want to make sure it's all set up under your name. Email tracking is a great way to go. You should also consider trying to understand where the email leads are coming from. So if you can track those on the front end when the leads are coming in, then you can dump those into your practice management software. It's a great way to go. Call tracking is an essential way, especially if you're engaged in any type of advertising on the web like AdWords. This is actually called, sorry, this is a little blurry, but this is actually called DNI tracking, which is dynamic number insertion, call tracking. So what that does is tracks the patient's journey. So a lot of times patients may start out by typing in organic search or free search, maybe your doctor's name or something. And then they may come back and type in, spinal doctor or orthopedic surgeon. So you want to make sure that you're tracking that user for their whole journey. And that's what the call tracking actually tracks users as opposed to just one. Okay. All right. And that's it. Some questions here for agencies. You just want to make sure that you own the website. You want to talk about those things. Who owns analytics? Who owns AdWords? When you're looking at a company, how long will website development take? Will the hosting be included as an extra fee? Again, will my content be unique or original? Again, content is huge. And then how will SEO efforts be tracked and reported? Who will be my point of contact? That's what you want to make sure you're asking, and that you're going to work with that person as well. We'll wrap it up here. Thank you.
Thanks, Keith. Next, we have Dr. Frank Phillips, past president of SOLAS from Rush University, talking to us about how to deal with industry.
Thanks, Jay. And I know the last two speakers are standing between you guys and the bar, so I'll try and be to the point, and I only have about a third of slides the other two previous speakers have had. So yeah, I mean, this is a common issue. I get asked it all the time. I've been involved in different ways with different types of industry for many years, from startups to big companies, and I think it's an area where when you're starting off your career, you've seen people and you sort of think it's a cool thing, but you're not quite sure how to do it. So hopefully I'll give you some very practical tips. So I'm going to sort of get through the philosophy slides and get down to the nitty-gritty. So just think about this. Intellectual property is really the key to being in a powerful position when you either start a company or you deal with existing companies. So think about it. These are just some terms. Patents obviously protect the inventions. Trademarks protect the identity. Copyrights prevent, to some it does, protect the expression. And trade secrets obviously protect your secrets. Really, patents are what are king in sort of the environment we live in. To get a patent, what does that mean? You have to have novelty, which means the invention has to be new. it has to have utility, so it has to be useful. So you can't patent something just because it's a new idea, but it's crap. It has to have some type of utility, and it has to be non-obvious, and that's really a key one. And I've been involved helping some in patent lawsuits where the other side would claim this was obvious to someone skilled in the art, so you should not give that a patent, because anyone could put one and one together and come up with two, so why are you giving these guys a patent? So it's important that it would not have been obvious to someone skilled in the art, in other words, someone in the spine world, when you pursue that patent. Marketability is not a requirement. So in terms of the process, the rules are it's the first to file, right? So it doesn't matter, which obviously favors big, huge companies because they can file patents all day. It used to be if you wrote an article and then someone sort of developed that and then filed it, the article would be prior art and maybe protect you, but now it doesn't matter. It's the first to file. You can easily do a patent assessment on the uspto.gov site. I mean, it's a lot of work, and it doesn't give you all the answers, but it's a very good, if you think you've got this great idea, it's an easy first step, and if you see, 3,000 other ideas similar, you're probably not going to pursue it. You prepare an application. Usually you need a lawyer. It's not very expensive to to initiate the patent process. It gets expensive if you're getting serious about it and you say, well, I'm going to do it in Europe, and every area in Europe requires a different application, and that gets crazy expensive. But the initial process is relatively inexpensive with a lawyer. You file it at the U.S. Patent Office, and then it goes to the prosecution, where you go back and forth with the Patent Office until hopefully the patent's granted or issued. So why does it matter? I mean, unlike, we kind of get lumped in the drug world, there's no clinician who's treating diabetes who's going to invent like a new drug to cure diabetes, right? But we're in the unique position where we're in the front line. We actually can invent innovative, creative stuff in our everyday life that matters. So, surgeons like to be problem solvers. We're on the front line. We use the technology. We understand what we're trying to achieve. And we're uniquely positioned to participate in developing new ideas, innovating. And when you think about it, innovation for the sake of it, saying, well, I can invent a cage that's got an extra this and that. You've got to say, does it solve a real clinical need? Because those are the inventions that are going to really be valuable. Just doing things because they're a little different, it's probably not going to be valuable either to the field or financially valuable to you. You've got to think outside the box. In today's world, you've got to really think about the regulatory pathway. You can have a great idea, but if it's going to be an FDA, PMA study, 5 years, $80 million to get to market, probably going to be a long road. And then reimbursement. You're much more likely to be supported and get traction if there's a somewhat ready reimbursement path for this idea. So you've got to think about all of this. I'm going to skip through these kind of innovation slides. So you have a great idea. So the first thing is high return in the field. Get the initial patent work done. It's pretty easy to do. Then you have sort of options. You can go it alone. You can say, I don't need help. I want the whole company for me. So it's expensive, but obviously you're putting money in and time, but it's a high potential downstream reward. It's very time consuming if you're doing something serious and hard to do while you're practicing. And most people have limited expertise. We're not all engineers. We're not all MBAs like Tom Char. You got to kind of figure it out on the go. So the next easy way is you got to raise money. So you have angel investors who are family, friends, which is good because, they give you a little bit of money. They're not really intrusive, but you don't really get much expertise. You just get money. And the most common mistake I've seen, inventors think all they need is money and they'll be successful. And the truth is that's the last thing you actually need. I know nobody believes me, but I've been doing this for a long time. All these guys, they start a company, they go, if we can raise $2 million, and no, you guys don't have a clue because you're going to suck at doing what you do. And you could give someone $2 million and they're still going to suck at what they do. So money isn't the only thing you need. VCs obviously provide a lot of dollars and expertise because they've done it. They do it for a living, but you're paying the price where you lose equity. They're going to hit you pretty hard, and you start off only 100% and come in suddenly you own 12%. It's not a good feeling. And they get control, but you do get expertise with your money. And also, they tend to have a shorter term horizon. Like they're not going to invest if they're going to have to stick with you for 10 years. They want to be out of it in 4 years. And then the last option, which is obviously the easiest, is to partner with industry, so partner with spine companies. So they have expertise, they understand the market. Obviously, it mitigates your financial risk because the company you're working with is going to spend most of the money. Remember, interests are not always aligned, right? Like they may have a slightly different idea of where this is going. Like you have a great idea, but it's going to cannibalize the existing pedicle screw business. They might go, yeah, this is really good, but like we make a lot of money off pedicle screws. We're not going to rush to market with this. So you have to be sure that you're aligned with the company, which takes trust, and you've got to learn to know each other. Obviously, if you're dealing with industry contracts, need legal scrutiny on your side to protect you. And you should never, this is really important, never deal with reps or sales teams. And that's the most important and the easiest route to go, right? You're talking to your rep, where he brings his regional sales manager, and they say, oh, we love you, you're using a crap load of a product, and you're sitting in the restaurant, you say, oh, I've got this idea, that's not, and then you say, like, start talking. It's really bad from a legal point of view. So you want to deal with management, executives, the development team, not salespeople. It's a bad path to go from protecting you, compliance point of view. And just remember, these relationships in today's world, Sunshine Act and all the others, everything you do is public. So remember, keep that in the back of your mind. So when you partner with industry, it takes time. It's trust and relationships. And I see some of my partners come in super aggressive and they go like, the world owes me, like industry's making money off me, screw you, you need to like take care of me, it's my time. And it doesn't work. It's a small world. People go from company to company, executives, and if you piss them off, they say, we don't want to work with you, you're a pain, we're never going to work with you, and your reputation, that gets around. So build trust, build relationships, and the more you build that, the more opportunities come your way. Generally, when you work with the industry and you've got a very early stage idea, they're not giving you a lot of money, right? They're going to give you a royalty-based agreement. So they're going to say, okay, partner with us and we'll give you 8% of future sales, which sometimes sounds good, but you've got to assess the size of the market and company penetration. So if you've got a cool widget and it's some small company, probably at the end of the day, they'll like have a tiny share of that widget market and the royalties are not going to be much. On the other hand, you have a pedicle screw product. There are a lot of guys who back in the day with, for example, Medtronic, who had 80% of the market. You had a non-innovator, but you had a royalty on their pedicle screw. You were making tens of millions of dollars. So you got to, when you think about royalty, think of what that means. Further along with your invention, you may get some upfront money, so an outright sale or licensing of your product. Often that's milestone based. It used to be, okay, you got a great idea, we love it, $100 million. Now they're going to say, we'll give you $10 million up front, then we're going to give you $10 million when you get through the FDA, then we're going to give you $10 million when you do this. So it's typically going to be milestone based, which is, if you're a big spine company, you're going to do that. You don't want to take the risk. So you got to just be prepared to deal with that and think it through. And again, dependent on your partner, may want to cannibalize existing products. Sometimes you want to get going and they've got 3 million products and they say, well, we're getting to it. This isn't our priority. So you got to figure that out and you lose control. Obviously, they're going to have their own engineer, their own business people. But obviously, that's probably the most sort of straightforward path to commercialization. So when you work with the industry, this next few slides are important. You want to sign a non-disclosure agreement, right? That really protects you and it protects industry, right? Because you really need that, because otherwise you can share your idea and they say, yeah, we were doing that anyway. So you got to have an NDA signed. And you got to think about how much you want to disclose prior to the NDA, because companies won't just sign an NDA, right? Because they've got a lot of things they're developing and they don't want to see your idea and sign an NDA and then they've signed it and then they say, after the fact, but we've already been developing this, and then it becomes a mess. So you got to just disclose enough to get them interested in your NDA, but not give everything away. And as I said, work with corporate, not with sales. And then we talked about the patent. Generally, you should file it before you disclose it to a company. If you haven't, you're still sort of protected with a non-disclosure agreement. But I think it's cleaner, easier, if at least you filed it. You can modify patents, and there's a lot of steps along the way, but at least have something filed. As I say, it's pretty easy to do it online, but I would say it's going to be a few $1,000s to get a patent attorney for that initial step. The other issue you need to think about, because that's going to come along earlier, not everyone's going to have great ideas, is consulting agreements, right? So it's heavily regulated, scrutinized by the Department of Justice, OIG. So these are the requirements for a proper consulting agreement. And this is really important, because you'll get this early on in your career. They need to be in writing, signed by both parties, no verbal stuff. It has to precisely detail your duties. So it can't just say, yeah, you're going to help us, company A, develop some next great thing. It needs to define exactly what you're doing. It needs to specify the time required with precise rate. And it can't just be made up numbers. It has to be the market rate. So no one's going to give you a $5,000 an hour. The market rate's probably closer to $400 or $500 an hour. That's what the rate has to be. It has to be at least 1 year. It has to be fair market value, obviously not related to sales or any clinical practice, which is why you don't want to deal with sales. And obviously your service must not violate state or federal laws, so like stock and antitrust and all other kinds of laws. When you do royalty agreements, most products have, so this is not your idea. The company says we're developing a new lateral, whatever, and we're putting, we want you to work and on that project with us and we'll give you some royalties. So most products have design teams, not an advisor, so the royalties are generally split. You're not going to get like 5% royalties if you're working with a company and you don't bring anything unique in terms of IP. And generally, royalty burdens are capped. Like you can't get any money for any device you or your hospital implants. I mean, most companies are smart. They don't do that, but you just got to be sure, because if you're getting royalties for anything anyone puts in your hospital or in your practice, that's a real no-no. And generally, the terms of the royalty, they can either, if it's a patentable device, which can be code-invented, so they say, we want you to work on our lateral approach, and you together, sitting with a company of engineers, come up with something novel and they file IP, you should be on that IP, on that patent. So then, then generally the royalty payments will be the life of the patent. If there's not IP, it may just be the agreement says this is a 10-year agreement and we're giving you royalties for 10 years. So you got to think through all those type of things. And that's going to be, as you get further along, a not uncommon agreement. So some practical advice. I mean, it's sort of cliche. The front page of the newspaper test is true, and even I've been doing it for a long time, and I legitimately think about that every time I'm talking to some company. Like if this was on the front page of the Chicago Tribune, would I look like a shady dude? And if the answer is yes, you probably shouldn't be doing it. And generally, if it sounds too good to be true, it probably is, because they're not free lunches. You got to provide services that you get paid for. And really go slow early in your career. And a lot of times fellows call me a year afterwards and they go, some company that I've never heard of are offering me all this stuff. And they know, like at that stage, you're sort of vulnerable. And really when, a year out, they're really more maybe interested in how many of their cages you'll put in than your real contribution to developing products. So just be careful early on. And the truth is, be patient. You think, oh my God, this is my first, it's an amazing opportunity. I guarantee in 2 years and 3 years, you'll have other opportunities. So just go slow if you like, when you deal with companies early on, because sometimes you get into a situation and it's harder to get out of it. Don't sign all-inclusive deals. Some companies in the old days were notorious, like you're working on a screw thing, but they'd say, your non-compete is anything that competes with this, and that basically means anything in spine surgery. So really narrow what your field is, what the scope of work is. Like say, if you're working on a facet screw, you shouldn't say screws, it should be very specific. Facet screws placed across the facet joint, ideally from medial to lateral in less than 8 millimeters. You want it as narrow as possible, so you can do other things with other companies and not compete with what you've signed on with company A. Don't be arrogant or naive. You're really not that special. You think you are, but there are a lot of guys like us out there, and there are a lot of smart guys, and everyone who's a spine surgeon is either a smart neurosurgeon or a sort of smart orthopedic surgeon. So you're not amazing. You are, but there are a lot of amazing guys that the companies can deal with. So remember that. Be humble, and at the same time, treat the people you deal with in these companies well, because you're going to need a relationship if it's going to be successful. And remember at the same time, not to be too cynical, but they're not really we all get close to the people in the companies, but ultimately their responsibility isn't to you, right? It's to the patients, really. It's to the shareholders to make dollars, and you're just a tiny part of that business, right? So just remember that. Be fair and cordial dealing with the industry. It's a small world. The other thing is disclose. It protects you. People feel nervous about doing it. I've always thought it's like the best protection. So don't feel bad. No one really judges you. And we've done studies like where we've asked patients in our waiting room and published, like, what do you think if your doctor gets royalties? It's bad. Patients love it. They think, oh, he's getting royalties. It must be really good. I love it. I want doctors that get royalties. So, yeah, but it's much better. Disclose to your patients is a big thing. If you're getting any agreement, put it in your, I have it in informed consent. I list every agreement in my informed consent to my patients. When you go to NAS or this meeting, CME, put it all out there. It's much better. It protects you at the end of the day. So spine rules to live by, put the patient number one. I mean, that's still, these other things are cool and seductive, but remember, we're still there to take patients, and don't ever do anything as attractive financially or otherwise it might sound if it compromises how you're treating your patients. As I said, all dealings should withstand the front page of the Tribune's test. Put another way, if you wouldn't be proud if your mother read it, don't do it. Other thing, it's all about taking care of patients. So all this other stuff we talk about in the end of the day in the operating room, we've got to be proud of what you did. Another thing I always find amusing, like I'd much rather be the quiet guy in the back of the room with all these things and I'm making crazy money than the guy who's like wants to be in Becker's and says, well, I'm in Beck's all the time because he's actually our practice attorney. So it's like unstoppable. He's been our practice attorney forever. But you know, like the guys who are like our front and center, that's like raising a red flag to the government. Like, oh, we sold this company for $400 million and it's everywhere. That's like the government saying, oh, we should check this guy out. So it's much better to just do your thing, but you don't have to be like making a big noise about what you're doing. Because remember, and I've not been personally involved, but I've been involved in companies, and when the government comes calling, you're done, right? Like the business, the VCs go, okay, find out how much we have to pay to settle this. Because they're never going away. They've got more money, they've got more time, they've got more resources than anyone. So you don't want to raise that flag and get anyone looking at you. So I'm going to end there, and hopefully it gives you a little idea about how to interact with this world around us.
Great, thank you. That was great. Final speaker, Dr. Denisa from Loma Linda. He's going to be sharing some of his lessons learned in practice management.
Okay, good afternoon. Those are really good talks. I'm Ali Denisa from Loma Linda, and so not too far from here. So I'm going to give you a little bit of talk on a little bit of my history or background with spine surgery. So let's go. Okay, and here are my disclosures to make Dr. Phillips happy. And so I don't think there are any conflicts here, but here they are. So for those of you who are spine surgeons, I mean, we all kind of share a background. And here's a little bit of my background. So when I was a young spine surgeon, all of us have a history where we've trained, and just like you, worked really hard. So for me, what's a young surgeon? It's either someone in training or the latter part of training or a new practicing surgeon. A few differences. Obviously, all of us are working very hard to perfect our craft. The ones who are in training, we usually have somewhat limited responsibility, but those who are out and about, we have the ultimate patient responsibility. Whether you're a day out or 20 years out, you still have that responsibility. And there are some financial differences between the trainees and the new surgeons. Interestingly enough, regardless of whether you're a young surgeon or an experienced surgeon, just like we talked about the topic here, business acumen, really we've spent such a long time learning about the art of surgery. What do we know about the business end or the business end of medicine? And most of us say very little. So I can say for spine surgery, for most of us, this is a thing coming from the JAOS, Yellow Journal in Orthopedics, about 20% of us go into academics, the other 80% go into some form of private practice. And that can be, you can see the minority there are in the solo practice, but the majority are either single specialty or multi-specialty groups. And now we even are having a greater number of people are going to be hospital employed. So that's the newest trend in surgery and in medicine in general. But so for those who are looking for jobs or thinking about jobs, what are the factors? Most of us will think like, one, you the surgeon, and these are the good questions. What am I good at? What am I not good at, and I think you should all think really hard and long about what that is, and what do I like to do? And also, what is the right fit? And it's sometimes very difficult to figure out for us when we're in training, what is a good fit for you? Some of the other options or factors are family, and you'd think the majority would say financials, making money. But interestingly enough, Merritt Hawkins' survey said 70% of us think of a desired location. So most of us, if you look in San Diego, boy, it's great to come out here. But if you look in spine surgery, I mean, everybody, you turn a corner, and the restaurant, there's a spine surgeon. So that may not be always the best place to be. So location actually is what a lot of young grads or people who are early in their careers are thinking about. So I talked about financials, and this is kind of crazy. So you think about financials. So in my training, that was about 20 years ago, but I was a PGY 7 when I finished. Look at how much a PGY 7 makes about now. And that's, thinking about, it's about anywhere from about $60,000, $63,000. But in contrast, look at the great mismatch where a lot of people who are in medicine now are in the negative. So if you think about it, about almost 40% have over $200,000 of debt, and about 60% of new grads have at least $100,000 in debt. So when you're making your decision, hey, what do I want to do? Have you ever heard that term, don't go shopping when you're hungry? Because that can be a big factor in when you make your decisions. So next slide, we'll say, okay, so the great, as Dr. Phillips mentioned, Becker Spine Review, the great expert or the great the book on spine surgery is the Becker Spine Review. So this kind of tells us, hey, look, you're in dire straits, but there's good news in your horizon. Look at that, what it says about for the median, this is the median annual salary for an orthopedic spine surgeon is about $750,000. Now that is a lot, and also for a neurosurgeon it's a little bit less because that factors in pediatric neurosurgery, functional also, but that's still quite good. Now for those who are in academics, unfortunately we make about 15 to 25% less, but that also depends on faculty rank and whatever, if you have a directorship of some sort. But look, there's also a regional variance, and you can see that, at least from this, the Midwest seems to be the Shangri-La of earning an income. So that almost puts you in the realm of either a very good minor league baseball player or a reserve on an NBA team. So that's really actually good money for someone who is in the negative initially, and then think about what's going on. Now, in the bottom, it says there what usually the entrance or the entry-level salary. It's still very good compared to someone who's making only about $60,000 a year. So, interestingly enough, then when you go, and it's even better when you look about a young surgeon. So usually I said a young surgeon is somebody probably in the first part of their career. After the 2-year guarantee, there's good news. You even make more money. Look at that. It's almost $1 million. And for those surgeons who are actively in the prime, where you're really good technically, you also are very efficient, and look at that, it's about 1.2. Those of us who are getting a little near the twilight of our careers still make a very good salary. So that's when we talk about money and how that affects your decision, what to look for, where to get a job. And we'll also add, finally, the all-important, interesting signing bonus. And it's interesting, I put this here with the signing bonus because a lot of people think, wow, more than just even moving expenses, the signing bonus can be a carrot that's been laid in front of you. But I want to warn you guys that the signing bonus can be, just like here, it's a tool to entice a beast of burden, and you might be one if you fall for that. So, interestingly, we talked about the finances, but look at this. This is a very sobering thing, also from Becker's. It says, for either neurosurgeons or spine or orthopedic surgeons, about 80% of people have left their first job within 2 years. So that tells me that even a young surgeon will be faced with, when you make a decision for a job, that you say, hey, this isn't for me and I'm going to have to leave. You can look at that in different ways of a breakup. Hey, it's you and not me. Did I make a wrong decision? Are the partners terrible? Is the practice experience bad? Or you can look at it in a positive sense. If that many people are having difficulty in changing jobs. So it may be an issue, it may be a slight setback, but at least so many people do it and can survive that, so it may not be a catastrophe. So this is me several years ago, and you can tell I had a lot more hair then. And at the end of my fellowship, I was very fortunate. I'm the son of two physicians, so I didn't have a debt. I was married and had, this is my son at the end of my fellowship. He was 2 years old. And so I really didn't have the monetary constraints or the worries that, or at least the financial burden a lot of people have. So when I talked to my mentors and said, okay, I've had this training, I'm going to work hard, and I wanted, this is what I want in the future. And I asked them, what are the pearls of my practice in the future? What are the pearls in developing a business model or being successful, not only in spine surgery, but also being successful as a doctor or as a business person? And it's interesting that it's usually somewhat monosyllabic. These really smart guys who I look up to, they said, hey, work hard. And what does that mean to me? Or that all-important pearl, the 3 A's were ability, availability, and affability. What does that have to do with business contract? What does that have to do with marketing and things like that? So for me, in my first job, I was in the middle of my fellowship, and I was looking for a job. And interestingly, and I have here the picture of my head was somewhat in the clouds, or probably somewhere in another part of my anatomy. I just kind of said, hey, And I actually, when I was looking for jobs, I went on 3 interviews, and all were, being the son of an academician. I said, hey, I like academics, clinical practice, research, yeah. Teaching, okay, we know working with residents and fellows can have positives and negatives at times, and I can tell you that very quite honestly. And so I went on the interviews, and on the interview process, because it was almost like one of those Charlie Brown cartoons. Their mouth was moving. I didn't even hear a word they said, and I said, okay. And I saw my senior potential spine partners were these famous people. And I said, wow, I've read your paper. It'd be great to be part of this club. So I looked at the employment contract, and I didn't even have an attorney. It's like, hey, I'm this one little guy, and this is a huge medical center. And so I just kind of signed on the dotted line, got my medical license, and matriculated and moved my family. Well, that was all good, and I started as a young attending at an academic institution in the Southeast. Interestingly enough, when I got there, the promise was, hey, look, you are going to be busy, you're going to show up, and you're just going to see, and they didn't lie, it was true, but interestingly enough, my practice was 80% in the community hospital of an academic center, and if you guys can see, that's Grady Medical Center. It's in Atlanta, and it's very busy, and the majority of the patient population are patients who are IV drug use, Hep C, and guess what? And so I was very busy and took care of pus. And I took care of pus and other people's disasters, people who had drug abuse, and I actually got very good at doing deformity surgery, and I mean bad deformity surgery. And taking care of that, I said, hey, this is an interesting patient population. I'd say almost 30% of my patients didn't show up for follow-up, which made me somewhat worried when I took my oral exam, because that's usually a red flag. And you really have to explain yourself why, hey, what happened to the patient? Oh, I did this huge surgery, and they never showed up for follow-up. And they kind of scratch your head. And if any of you ever, if you're orthopods, if you get an oral exam, you ever see Frank Eismont, or at the time, Henry Bowman, and they kind of looked at you, and he's like, oh my God, I'm never going to pass this test. But luckily, I did pass. But after that, this is obviously not me, but it was an episode of one of my favorite shows, Scrubs. And here you can see the 2 characters, there's JD and Turk, and that kind of was me, and the episode was burnout. And so I made it past the 2 years, but after about 4 years, I was pretty burnt out. I had the similar patient population, and I can't say I was either a good surgeon, a good person, or a good husband. And so I had to kind of have a come to Jesus moment. And I said, so basically I had to have some conversations with close friends, with my wife, who I consider a close friend, and with myself. And so I have to do almost like a reset and say, where do I see myself, and structure what my future is. So in the short term, in the midterm, and the long term. And so, as I said, you have an action plan, and you have, you know, what does it entail with my clinical practice? And I really wanted a little more variety. What I want to do with research, my involvement and to be more active in spine societies. And as Dr. Phillips said, you know, he talked about industry relationships. And just as an aside, when I was at Johns Hopkins, I was a biomedical engineering major. And when I was there, I actually helped or actually started and developed a humeral nail implant. And as you were saying, that's stuff like that takes time. So I actually sold that to Ace Nail, which was a company that's been sold out and bought several times. But the money I took from that I had, and which is interesting because I invested it, and I'm sure some of you know, I didn't make a lot of money. I made like a couple $100,000. I invested in a small company, which you guys would know, it's called Cisco, and that money has gone quite well for me. So. So the other thing I wanted to talk about was I had to develop a business sense. So that, unfortunately, these slides I switched from Google Slides to PowerPoint. So I kind of had to know what my insurance, getting a better understanding of insurance contracts, even though in academics you think like, hey, I just have to show up, and you know but knowing about insurance contracts, fee schedules, referral base, and just we had that very good talk on marketing. And also on whether, you know, for most people you think, hey, I'm going to go to a town, I'm going to be a nice guy, I'm going to smile, take call, and that's my practice, everyone's going to know about me. That's changed, even in academics. We have, as we said, you have to have an online presence, you have to be able to give talks, whether it's in online, whether it's in the societies, whether it's in local, so that, or even to your primary care facilitators. So, and the other thing I would say, if you know nothing, is to understand coding, which is interesting because coding is, for us, is directly responsible for our compensation and our reimbursement. Who has more of an input, more at stake than you, than someone who's making $12 an hour as a biller? So you should understand about coding. And if I were you, I would take a coding course about at least once every 5 years, and I've done that. And all our societies have them. The AOS has it, the AANS has it, and I've done that and refreshed and understand. Since you are the one who's doing the procedure, you should know what it all entails, rather than someone worrying about a Medicare audit. And that's, you know, so that's very, very important. Next, to understand productivity and compensation. When I came out, as I said, I was very busy. We had business meetings, and we were talking about, and I mean, very rarely even made it to those things. We were talking about things like RVS, and I was like, what the hell is that? Does that have anything to do with me working hard? You know, RVS was actually started in Harvard, and is like, I think in 1983, it's called Resource-Based Relative Value Scale. And that has now morphed into the RVU. Most of you guys, or people who are young, we talk about RVUs. It's been said that about 60% of all physicians, or actually 70% of physicians, are paid in some way due to the RVU scale. So when you look at RVU, you better make sure you understand what we're talking about. There are two types. One is the work RVU, which we know, and the total RVU. The work RVU, as it says there, is a standard for the value of work. So it actually can follow and show how productive you are, and it also is directly responsible for your compensation. Interestingly, the work RVU, it's blind to payer mix, it's blind or the amount of revenue generated, and it's irrespective of the specialties. You're just giving a number for what you do, and it's also irrespective of geographic location. The total RVU is a little different because you have to take in consideration not only the work RVU, but the amount or the practice expense. And finally, the malpractice expense. So it's the relative risk of a CPT code. And then you merge that into what we call the geographic cross-practice index. And that's the bottom formula looks like something I used to hate doing, like algebra or something in like 10th grade. But so you take the work RVU, the practice expense RVU, the professional RVU, and that gives you the total RVU of the RVU itself. Well, what does that mean? Well, CMS is the one who uses the RVU, and they take that RVU system and they put it with a conversion factor. Now that conversion factor, some people have said that's either $36 or $40, and that tells you how much you're going to get paid for a procedure. So interestingly enough, I was going to say, For those of you looking at jobs, the median RVU for a spine surgeon a year is about 12,000 RVUs. If you are 75th percentile, it's about 16,000 RVUs. If you are doing these huge deformities and you're really humping it in the 90th percentile, you're doing about 20,000 RVUs. So you better be, so it's a good idea to know what those numbers are, because when you get these jobs and say, hey, this is how much you get paid, and then you want to know how to, if you can keep that up, you better know how many RVUs you're going to generate. And I just actually talked to, since I'm a member of NASA, I talked to Alison Waxler. She also, if you look at Spineline, they kind of show you, they give you CPT codes and kind of say, this is how much you get. Well, with the conversion factors, with the RVUs, and so I took pretty simple procedures that can be done and looked at surgery centers, for example, like ambulatory surgery, T-lift, direct lateral, as well as an ACDF, and you see the Medicare payment. Well, what does that mean? So that's the Medicare payment you get. So that's what Medicare pays you, that's government pays you. But what about private insurance carriers? Most of us know that you can bill 200 times but what are you going to get paid? So well, in California, we see certain things and say, what's a good payer? Well, they pay 100, you hear it, they pay 110%, 120%, and then workers' comp is a mixed bag because it depends where you are. For example, in California, we usually get anywhere from, for workers' comp, 120, 130% of Medicare. Now, those of you, if you deal with workers' comp, we know we have poor outcomes, the patients, the paperwork, is it really worth it? However, a good friend of mine who finished fellowship or did residency with me in St. Louis, he says for an ACDF, single level, he gets paid by workers' comp $18,000. So 10 times what I would probably get. That's why he makes $2.5 million a year. Okay, all right. So the other thing about in business is to get a good idea. Those of you who are into solo practice or well-managed practice have to understand about overhead. Overhead is basically what it takes to run a business. And there are lots of facets to overhead, and it's a good idea to kind of understand what it takes to run a practice. And look at the things, salaries up there, wages, obviously you got to pay not just yourself, but the people who are out there who are working for you. EHR, electronic medical records, is a big hit, medical supplies, all these things. Outside professional fees, marketing, but look at this, I put there, for example, professional liability insurance. Why is that a big deal for spine surgeons? Well, guess what? That's a big deal for us, okay? We actually, in New England Journal of Medicine was an article, when they talk about, if New England Journal of Medicine talks about it, you know it's a big deal. It's not just JNS or AOS. They talk about malpractice risk per specialty. And there it talks about over 40,000 surgeons, 25 specialties. If you look at the numbers of just all physicians, about 7.5% have a malpractice claim, not paid, but malpractice claim a year for high-risk specialties. And who's that? Spine surgeons, okay? Neurosurgeons, orthopedic spine surgeons, or OBGYN, and almost 20% have annual risk. And if you look at by age, even when you're getting to from the young surgeon to in your career, by age 45, 88%, almost 90% will have at least one claim, and by 65, pretty much everyone gets a claim. So what does that mean for those of you who are a spine surgeon? Excuse me. Okay, I'm sorry. All right, so you will be sued, and so it's a good idea to know where you practice and know about tort reform. California, that's where I am, and luckily for us, we have MICRA, we have tort reform cap. So when you're looking for jobs, the key is to get the sweet spot. Do what you love, what you're good at, and what pays well, and the sweet spots, that's the one to hopefully to aim for. And when you look at, when you're looking for jobs, employment contract, don't be like me, at least initially, do your due diligence. Speak to an attorney, talk to your partners, talk to people who preceded you or competitors, understand your compensation. Can you attain those goals? And obviously things like path to partnership, and be wary of signing bonuses. And finally, one of the things about personal business management. So those of you who are married, hopefully you're all married and married well, made the right decisions. When you're out, that is not the time to think of an upgrade. So that could make things very difficult and both financially and personally for you. Spend wisely. So you're not really a millionaire if you spend $999,000. Well, an example is Allen Iverson, he's an NBA Hall of Fame. He made $200 million in his career, and he's penniless. So you can't say he's wealthy. Financial planning, and also take good care of yourself, both physically and mentally. Finally, conclusions. So my advice is just like they said, work hard, okay? Work hard. And so this is Society of Lateral Access Surgeons. For me, when I got out, lateral access surgery was a huge thoracoabdominal approach. Now, I'm taking a second year resident through direct lateral, minimally invasive. Patient goes home the same day, or at least the next day. But also the other things about when you're looking for a job, do your homework, investigate, don't be dazzled just by pure money, and learn as much as you can about the business of medicine. It's your work, be compensated. And I love this saying, I think Praveen Mumaneni talked about this at a meeting. You earn your seat at the table, because if you don't, you might be on the menu. And in your personal life, live wisely and spend wisely. And that's my family. That's the 2-year-old kid, now graduate from Virginia. He was summa cum laude. He now lives in D.C., and he is a lobbyist. Okay, thank you.
Great, thank you. Well, we are way over time, so why don't we take any conversation to the bar, and appreciate everybody staying so late on a Friday, and thank you to all the speakers for volunteering your time. It was very productive. Thanks.